Estimados
Buenas
doctores,
noches.
buenas noches. Doctora Cabrera, puede iniciar, por favor. Gracias.
Buenas noches, queridos colegas, queridos amigos. Bienvenidos a la sesión inaugural de este año 2026. Hola, Edson.
Buenas noches con todos. Bienvenidos igual a la primera reunión de este año. Empezamos así.
Problemas del audio, creo, ahora sí.
Ok. Bien, vamos a empezar entonces con la lectura del acta de la sesión ordinaria. Vamos a leer la acta ordinaria de asociados. En Lima, a los 18 días del mes de noviembre del año 2025, a las 8 horas, se reunieron los asociados en el auditorio de Laboratorios Megalabs, en Magdalena del Mar, teniendo como presidenta a la doctora Cecilia Cabrera Cabrejos y como secretario general al doctor Edson Guzmán Calderón, y se procedió a iniciar la sexta sesión del año. La lectura del acta anterior, el despacho fundamentalmente se recepcionaron cartas procedentes del Colegio Médico del Perú, una de ellas haciendo llegar la invitación para asistir al 11º Congreso Médico Nacional, donde para la Sociedad de Gastroenterología del Perú fueron aprobados 2 delegados plenos y 2 delegados fraternos con derecho a voz. Una segunda carta donde se hace llegar la invitación para participar en la ceremonia central del 61 aniversario del Colegio Médico del Perú, a realizarse el 16 de octubre en el Centro de Convenciones. La tercera carta nos hace llegar la invitación para participar en la reunión de instituciones médico-científicas a realizarse el 28 de octubre en el decanato del Colegio Médico del Perú. Los informes, en atención a las cartas respectivas del Colegio Médico, para los delegados plenos se mencionaron a la doctora Cecilia Cabrera Cabrejos como presidenta, y delegados fraternos la doctora Melissa Villapuerte Méndez y el doctor Dacio Cabrera Hinojosa. La ceremonia central por el 61 aniversario fue designado como representante el doctor Hugo Cedrón Cheng, que es el vicepresidente de la Sociedad de Gastroenterología del Perú. Las reuniones de instituciones médico-científicas contará con la participación de la doctora Cecilia Cabrera, y la Convención Nacional Estatutaria estará participando la misma presidenta de la sociedad, la doctora Cecilia Cabrera. En fecha del 18 de octubre se llevó a cabo la 4ª edición de Enredados Internacional en modalidad virtual, donde en el bloque de análisis de casos clínicos de alto impacto se trató temas de gastritis autoinmune, hemorragia digestiva, eje refractario, contando con la participación del doctor Dacio Cabrera, representando a la Sociedad Interamericana de Endoscopia Digestiva, al doctor Gustavo Quiroga como moderador, en representación de la Sociedad Peruana de Gastroenterología, y al doctor Hugo Cedrón como experto y representante de OPE. En nuestra página web, así como en las redes sociales, se contó con la valiosa colaboración de la Sociedad de Gastroenterología del Perú a través del doctor Alejandro Piscoya, Paz Presidente, y el doctor Jorge Espinosa, coordinador del capítulo de Gastroenterología Clínica. Además, comunicamos que la Junta Directiva, junto a los capítulos que vienen desarrollando actividades científicas para el 2026, como son los talleres hands-on, las sesiones científicas, y el 29º Congreso Peruano de Enfermedades Digestivas, y que se llamará Gastro Lima 2026. En orden del día se solicita como incorporado, como miembros adscritos, la doctora Elizabeth Contreras Chávez y el doctor Felipe de la Torre Araya. Como miembros asociados, Edson Gudiel Palomino, Félix Quispe Morote, Patricia Sea Villena, Enaida Medrano Palma, Diego Basaldúa Chincha, Jocelyn Valderrama Coy, Sandra Lucía Valer Alemán, Almendra Gómez Sánchez, Judith Catherine Sánchez Zabaleta y Wilber Ismael García Lévano. Para finalizar la sesión científica, se llevó a cabo la sesión científica del capítulo de gastroenterología clínica denominada pancreatitis aguda, teniendo como ponentes al doctor Néstor Palacios Brown, cirujano del Hospital Revaldiati Martins, con el tema nutrición en pancreatitis aguda, cuánto y cómo iniciar. Al doctor Ricardo Prochaska, y con el tema prediciendo severidad en pancreatitis aguda, práctica actual y futura, y como moderador al doctor Augusto Vera Calderón, Paz Presidente de la Sociedad Peruana de Gastroenterología y DESI. Finalizada la reunión científica y no habiendo otro punto de tratar, se levantó la sesión a las 22 horas del mismo día, y con esto doy pase a la Cecilia Cabrera.
Gracias. Voy a leer la agenda del día de hoy, el despacho y los informes. Con fecha 27 de diciembre de 2025, la Organización Panamericana de Gastroenterología y la Unión Europea de Gastroenterología convocaron a 2 candidatos para el Summer School del año 2027. Del año 2026 se enviaron 2 candidatos. Asimismo, el Colegio Médico del Perú solicitó nuestra participación en el Congreso Médico Nacional al cual se asistió. Además, se otorgó el auspicio para el 10º Congreso Internacional y Premio APG a la Investigación de la Salud bajo el título Innovaciones Tecnológicas en Medicina. Tengo el agrado de informarles que ya tenemos el cronograma de las sesiones científicas para el año 2026 que se encuentran en nuestra página web. Serán siempre los terceros martes de cada mes. Y me complace mucho en anunciar nuestro GastroLima 2026. Ahí les estamos mostrando el flyer que se llevará a cabo del 26 de agosto al 29 de agosto en Lima, en el Swiss Hotel, y constará, como siempre, del Congreso de Patología, el curso internacional de avances en gastroenterología clínica, el curso internacional de endoscopia diagnóstica y terapéutica, así como el hands-on. Este año también en nuestra filial Cajamarca tendremos un curso regional del 25 al 26 de septiembre de este año. También me complace en la orden del día informar de la incorporación como miembros adscritos de la doctora Rebeca Elizabeth Gutiérrez Valeriano, médico residente del Hospital Carlos Alberto Seguín Escobedo de Arequipa, la doctora Medellín Ángela Herrera Alzamora, médico de segundo año del Hospital FAP, la doctora Karen Portilla Berrú, médico residente de segundo año de gastroenterología del Hospital Belén de Trujillo, el doctor Ovidio Robert Villena Veneros, médico del segundo año de gastroenterología del Hospital Belén de Trujillo, y la doctora Diana Pomizarra, del primer año del Hospital Daniela Cíes Carrión. Eso es nuestro despacho y nuestros informes, y a continuación quiero dar pase al doctor Kishimoto para presentar nuestra sesión científica de hoy, inaugural, con 3 ponentes de lujo. Endoscopia avanzada, tips de expertos, a cargo del capítulo de endoscopia digestiva. Muchísimas gracias, doctor Kishimoto, and welcome, Dr. Ohata and Uedo. Thank you very much.
Muchas gracias por el pase. Muy buenas noches a todos, colegas conectados desde Perú y Latinoamérica. Nihon de konnichiwa. Sean bienvenidos a esta primera sesión científica virtual de la Sociedad de Gastroenterología del Perú, denominada Endoscopia Avanzada, Tips de Expertos. Soy Gustavo Kishimoto y tengo el honor de moderar este encuentro. La cirugía endoscópica no es solo una habilidad manual, es una ciencia de decisiones críticas. Para nuestros residentes y fellows que nos acompañan hoy, el objetivo de esta noche, al margen de admirar la destreza técnica, esperamos que puedan entender la estrategia mental detrás de cada movimiento. Es decir, qué detalle nos hará ganar precisión en nuestra práctica diaria. Hoy tenemos el privilegio de acortar nuestra curva de aprendizaje bebiendo directamente de la fuente de conocimiento. Tenemos el honor de compartir con 2 de los máximos exponentes de la escuela endoscópica japonesa para que compartan con nosotros esos tips, esos secretos que usualmente toman décadas descubrir. Sin más preámbulos, comenzaremos este viaje hacia la excelencia endoscópica. Iniciamos pues esta sesión de lujo con un invitado que redefinió la práctica diaria en Tokio. Para nuestros residentes y jóvenes endoscopistas que buscan el ojo clínico perfecto, es un honor presentar al doctor Ken Ohata. El doctor Ohata no solo es el jefe del Centro de Endoscopia del NTT Medical Center of Tokyo, él es quien supervisa el centro con el mayor volumen de disección endoscópica colorectal de todo Japón. Hoy no viene solo a darnos una teoría, sino también enseñarnos a ver lo invisible, ¿no? La predictibilidad de invasión. Antes de levantar el bisturí hay que saber a qué nos enfrentamos. Doctor Ohata, es un privilegio tener su experiencia en la Sociedad de Gastroenterología del Perú. Dr. Ohata, it's a really privilege to have your expertise at the Peruvian Society of Gastroenterology. どうぞよろしくお願いします。
Thank you for your kind introduction. And it's my great honor to having this kind of opportunity. So, my name is Ken Ohata from Tokyo, Japan, and today I'd like to talk about how to diagnose the depth of the tumor infiltration in colonic polyps. So, and this is today's agenda. And first, I'd like to talk about the guideline in Japan and the Western countries. So in Japan, the classification sometimes differ from the pathologist. The definitions are somewhat a little bit vague. So, and this often leads to the problem. So the Japanese style, based on the cellular TPA and the structure of TPA, and the Western countries with a submucosal invasion or not, more clearly and more simple, I think. So the left is a Japanese style. The cancer, with even the filtration limited to the mucosal layer, but in Japan, it's classified as a cancer, but in the Western country, it was diagnosed as a dysplasia. That is a bit different. But Western country, the lesion infiltrate to the submucosal layer became diagnosed as a cancer. The baseline, the classification, really different. And this is I'd like to talk about the Japanese strategy, the treatment strategy. So this flowchart is treatment strategy after endoscopic diagnosis. We can diagnose T1, TIS or T1 superficial or T1 deep or not. So we separate like this. And if the lesion is possible to remove by EMR, endoscopic resection with this line, but we decided it's difficult to remove endoscopically, so go to proceed to the surgery. And after the endoscopic resection, pathologist diagnose the depth of the tumor infiltration, and if the lesion invade to deep submucosal layer, we decide to proceed the surgical resection. And if the lesion limited the superficial submucosal layer, the patient proceed to the surveillance course. So, and the pathological diagnosis is very important. This is the lymph node metastasis by the tumor infiltration. If the lesion limited to the 1,000 micrometers in submucosal layer, it has no lymph node metastasis. So based on this, after the endoscopic resection, we divided the surgical course or surveillance course like this. So, and after the endoscopic resection, the vertical margin and submucosal invasion or lymphocyte infiltration and the budding, we determine whether surveillance or surgery, like this. So the submucosal invasion is limited to 1,000 micrometers, like this. And the next, I'd like to talk about the diagnostic routine. So it's important to transmit the tumor characteristics or something in without a video or without a picture. So how to transmit? So how to talk to the others. So first we have to record the location, where is the lesion, and like this. So if the lesion located in the rectum, the lesion is nearby the dentine line or more inside or from how long from the anal bulge or something. That's important to record it. And also important to mention the size of the lesion precisely. And for the small cases, we use a measuring device like this. And some cases we use the endoscopic diameters like this. So we estimate the size according to the diameter of the endoscope. And also sometimes we use the device diameter to estimate the size of the lesion like this. When I close with the devices that are around 2 millimeters or 3 millimeters, and want to open the cup, so the size is 7 millimeters, like this. And also important thing is the gross appearance. So the macroscopic type is important, especially the 2C type lesion sometimes has a different characteristic of the cancer pathway like this. So the adenoma, as well known, the adenocarcinoma sequence of the gross morphology is an elevated type and became an advanced cancer, but the 2C type lesion has a different pathway to the cancers. So the lesion, the breast type has a de novo pathway, and the lesion has a different characteristics and also the different potentials. And also the important, the laterally spreading tumor, LST. So LST is not macroscopic type classification like this. So the LST is a gross pattern classification. So the macroscopic type means like this, the 2A or 2C, only depend on the macroscopic morphology. But LST include the growth patterns like this. And LST is a superficially colorectal lesions, 10 millimeters or more in diameter. And also it has a horizontally, laterally growth pattern. It has a. And LST is classified as like these 4 groups, the homogeneous type, and including the huge nodular mixed type, and LST non-granular, flat, elevated type, and LST should depressed type. Classified like 4 groups, but some cases, some LST express the mixed type, classified as the mixed type groups like this. But based on these 4 groups, each group has a different potentials. Granular and homogeneous type has a low submucosal invasion rate, even if the lesion becomes bigger and bigger. On the other side, pseudo-depressed has different potentials. From the small, even if the lesion is small, like this, but high submucosal invasion rate. So it has a different potential, the homogeneous type and the pseudo-depressed type. And also same non-granular, flat, even if in the same groups, like a non-granular type, but flat elevated type has a one-side invasion like so. But a pseudo-depressed type of multifocal invasion like this. So the in a way of invasion is different between flat elevated type and pseudo-depressed type. Next is about the depth, how to estimate the depth of the region. So with a wide light image and image enhanced endoscopy. conventional endoscopy is a minimum basics of diagnosis. And I will show the findings, how to suggest, how to estimate the submucosal invasion. So the endoscopic finding is basically depend on these 3 points. So these 3 points. Findings due to rupture of the muscular mucosal layer, and the findings due to the extensive submucosal tumor infiltration, and the findings due to the fibrosis based on the cancer itself. So these 3 points is very important to estimate the depth of the tumor infiltration. So these 3 points, these 3 change reflects. So the endoscopic findings reflect these 3 changes caused by the cancer. The first, expanding appearance, as if like an overinflated balloon. So expanding appearance is one of the important points to estimate the submucosal invasion. And the next, uneven and irregularities like this, not a smooth surface. Smooth, especially the observed and submucosal deep invasion cases. So unevenness, irregularities, and also often mix these forms like expanding, overinflated, and also it has some irregularities, not smooth form. Not only expanding, but also the not smooth form is a deep invasion. It reflects the deep invasion of the submucosal layer. And the next finding is the depression, like this. So this region also has a depressed area, the depressed area. Clearly demarcated depressed area means submucosal invasion. And this is also the depressed area, but it has elevated part inside the depression. It also reflects the deep submucosal layer, and also the redness. So this finding is a redness, strong redness. In general, more strong reading in the correct tumor, the more atypical dysplasia it is. So, like the strong redness. Also, these findings expanding and irregularities and strong redness, like this. And another finding is fold convergence, like this. Fold convergence. This also has a fold convergence like this. So at least more than 3-fold conversion like this, it means a deep submucosal invasion. It has a more than 3-fold is appeared. But fold convergence is not it's not fold conversion appearance is not used for the non-granular type lesion. So because non-granular lesion often has a multiple fold convergence like this. But this lesion do not this lesion is a non-granular type, so we don't use a fold convergent appearance to estimate the submucosal invasion. Only for the elevated cases. This is not LST, so fold convergence means submucosal invasion. Also, to diagnose the depth of the tumor invasion, we use image-enhanced endoscopy. As you know, the NBA. NBA has been studied by the Professor Sano since 1999, and they use two wavelengths, which are narrowed by the dedicated optical filter to suppress the reflection of blood. So it reflects the surface pattern and the vessel pattern. But important thing, surface pattern is not a pit pattern. So we use a pit-like structure. The white zone, sometimes we call the white zone, but it's like a pit-like structure. It's not equal to the pit pattern because as you see, this is a pit, and here is a pit, but pit-like pattern is different. It includes a marginal cryptic stereo like this. So this area is shown by NBI, but this area is the real pit pattern, true pit pattern opening, and in addition, the marginal crypt epithelium is a pit-like structure, the white zone. Then the NBI is reflect what NBI showing the pit-like pattern. Pit-like pattern is a surface pattern. So, and this is a NBA appearance and showing the white zone, not the pit pattern. And this area we use a CRISPR violet staining, and this is a real pit pattern. Though this picture shows the same area, but as you can see, the surface pattern is different because this is a white zone, the pit-like pattern, and this is the staining appearance show the real pit pattern. And also NBI showing the vessel pattern like this. And it was classified as type 1 and the type 2A and the type 2B and the type 3. Like this. Type 1 is a hyperplastic polyp, and type 2A the low grade adenoma, and type 2B a high grade, and the type 3 high grade to deep submucosal invasion cancer. So the type B is wide, include a wide range, and the type 3 mean the deep submucosal invasion. But type 2B has still problematic. So the type 2B is still problematic. Type 1, the type 2A, and the type 3 of the JNet classifications were very reliable and they indicate hyperplastic, low grade, and SM deep carcinoma, respectively. But specify the positive predictive values, PPV, of type 2B were relatively lower than those of others. And several studies also showing the PPV of JNet type 2B is low, like this. So similar trend was observed. So we diagnose white light image and NBI and watching the surface pattern and the blood vessel patterns. And if we faced to the type 2B type 2B of JNet classifications, we use the dye endoscopy by the crystal violet like this, and watching the real pit pattern and classify the lesion more precisely. So the pit pattern reflects the real, more reliably reflect the real pit patterns. So, white light image and NBI, and if you diagnose type 2B, it use staining way to classify type 2B to the, and then classify with a pit pattern, and type 5 irregular or low, type 5 irregular high. That means non-structure. Type 5 non-structure or type 5 irregularity low, high irregularity or non-structure. So chromoendoscopy pit pattern observation should be performed if we diagnose type 2B. But actually, at present, so the crystal biopsy is not allowed to use because of the potential of the cancer. So recently, many countries are prohibited to use, and recently in Japan also becoming. So the using the pit pattern is not necessary at present. Even if, but using the NBA is more safe and easy. So type 1 using the NBI and classified with the JNet, and type 1, type 2, type 2B, and type 3 should be done. And pit pattern is not always necessary, I think. So today I talk about the guideline between the Japan and Western country, and a bit different. So the Western country is more simple, and the Japanese guideline is really vague because of the based on the pathologists that sometimes differ. I think Western countries' style is more simple and clear. And also I talk about how to the flowchart of the treatment strategy, and also how to diagnose the depth of the invasion to the submucosal layer based on some fibrosis, so that endoscopic findings are reflected from the cancer, fibrosis, or muscular mucosa breaking or something. Then I talk about a bit talk about the image enhanced endoscopy. So today my talk is that's all, and the take-home message. So the endoscopic findings are always based on cancer, change cancers. So the endoscopic findings are caused by the cancer change. So it's important using the several methods, and always clear to define the treatment strategy for the patient, I think. So thank you for your kind attention.
Ohata Sensei, 素晴らしかったです。ありがとうございます。Muchas gracias, doctor. Ha sido una clase magistral sobre cómo el diagnóstico preciso dicta el éxito del tratamiento, ¿no? Ahora que sabemos qué estamos tratando y cuándo resecar, la gran pregunta para nuestros fellows es cómo lo hacemos, ¿no? Entonces, con tantas nuevas tecnologías disponibles, necesitamos una brújula para navegar estas opciones diferentes, y para darnos este norte estratégico damos paso a nuestro siguiente expositor. A continuación recibamos a una verdadera autoridad mundial en la estrategia endoscópica desde el prestigioso Instituto Internacional del Cáncer de Osaka. Presentamos a su vicedirector del Departamento de Oncología Gastrointestinal, doctor Noriya Uedo. El doctor Uedo es consejero de la Sociedad Japonesa de Gastroenterología Endoscópica y una figura clave en el desarrollo de las guías que todos estudiamos. Seguramente lo podrán reconocer de la clasificación de vasos y superficie con NBI, el JNET. Para la audiencia joven que a veces duda entre usar tracción, método convencional, underwater, el Dr. Uedo es un maestro que nos enseñará a elegir el arma correcta para la batalla correcta. Uedo Sensei, dozo, yoroshiku onegaishimasu.
Muchas gracias, Kishimoto Sensei. Buenas noches, everyone. Can you hear me? Now, is it okay? Okay.
Yes.
So, I share my presentation. Mm. Sorry, I'm not. Okay.
Mientras el doctor Uedo se conecta y comparte su presentación, realmente para usarla, para los que van a empezar la cirugía endoscópica, la palabra clave, como están viendo, es precisión, ¿no? Entonces, mientras más tengamos precisión en nuestros movimientos, va a ser más pertinente, ¿no? Dozo, Uda Sensei, sumimasen. Kikoemasen.
Dr. Ueda, we can't hear you. Oh, okay. We got your presentation. But we can hear you, Dr. Ueda. Your microphone is off, I think. Maybe.
Dr. Uedo, Kikoemasen.
Hello.
Ah, okay.
Okay.
Oh, hello. Now,
Yeah, we
is
can
it
hear you
okay now?
Okay.
Okay. Sorry about that. Okay, so this time, thank you for invitation. This time I'm talking about the different method of ESD. It's a little bit difficult topic, but basically, initially, we want to share the knowledge that the ESD can mainly divide it into the two major steps. One is mucosal incision, and then another is submucosal dissection. And today, I'm mainly talk about the process of submucosal dissection or how to improve. So, underwater traction or pocket creation, why do we need such kind of technique? Because it is very important to know about the principle, like adequate tension, tissue is efficiently cut. And also, it really clarify the submucosal plane and the vessel, and then we can perform prophylactic hemostasis, coagulation. So it is very important to know that the ESD, we usually use electrodiathermy to cut the tissue. So mechanical, if you cut the tissue with a metal knife, we need to move the device and then mechanical force to cut the tissue. But we use diathermy to cut the tissue. So device is not necessary to be moved. And then if you apply the diathermy spark, we can cut the tissue efficiently. And in this situation, we need this adequate tension toward the tissue from the both sides. And then another important point is usually if we cannot see the submucosa, because submucosa contain many vessels, it causes bleeding. And also bleeding always spoil visibility of operation field and then interfere the procedure and increase the risk of complication. So it is very important to avoid bleeding. And in such situation, if we have a very good tension toward the specimen, we can clearly identify the submucosal plane and then vessel. And if we can really recognize the vessel, we can prophylactically coagulate the vessel in order not to bleed, cause the bleeding. And initially, I start from explanation about the conventional ESD. So positioning or strategy based on gravity. So usually conventional ESD to achieve, so as I explained that the adequate tension, achievement of adequate tension to the tissue is very important, key importance for ESD. But usually conventional ESD, we use gravity. So we usually rotate the patient position and then better to make the lesion opposite side to the gravity. And then how we can identify or recognize the direction of gravity. So if you infuse some water, water is pulled in the gravity side. So opposite side to the gravity means the anti-gravity side. So if we make the lesion to this location, the dissection is easy because we can achieve adequate tension to the tissue, submucosal tissue. And how about the lesion located in a lateral side to gravity? So at the beginning, we really attempt to start from anti-gravity side to make a flap. But if we continue the procedure, eventually the lesion or specimen always shift to the gravity side. And then management of this gravity side become very difficult at the last moment. So usually we start from gravity side first. So that we can use the mucosal tension to make incision or initial submucosal dissection easier. And then after that, we address to anti-gravity side and then make a flap and then complete the dissection. And how about the lesion located in the bottom of gravity? So in such case, the situation is terrible. And then in this situation, such traction or underwater or pocket creation ESD is very beneficial. So I explained about the circumferential positioning. And then especially for stomach, it is very important to understand the longitudinal direction of positioning as well. Because stomach is a very wide and then little bit, very tortuous shaped organ. So usually longitudinal direction, gravity go toward the cardiac side. So we usually perform retroflex procedure for lesion in the corpus. And then lesion in the antrum, we perform downward procedure to achieve good tension toward the tissue by gravity. And initially, as I mentioned, ESD is divided into two steps. Initially, we perform mucosal incision like this. And initial incision, mucosal incision is better to be a little bit shallow because in order not to avoid or not to cut some mucosal vessel. And then after that, we make the incision line deep enough until surface of the muscularis propria. And this process is called trimming. And then this is very important because with this process, we can really evaluate entire layer of submucosa very well. And then we can decide the good submucosal dissection plane with this process. So this is the anatomy of vessel in submucosa. So usually vessel penetrate the muscle and then branching toward the mucosa, branching in the submucosa toward the mucosa. So shallow superficial submucosa has many tiny vessels, which may cause oozing. However, in a deep layer of submucosa, vessel is less. And then in between the vessel, there's a very loose, easy dissected plane exists. So recognition of such kind of whole layer of submucosa is very important. So for example, if we can really make the deep incision line, we can identify whole layer of some mucosa and try not to dissect superficial layer. Try to dissect deep layer, which is less vascular and less fatty. And we can recognize the surface of muscle and then parallelly dissect this good loose submucosal plane. So for example, this is still shallow, make it deeper, and then we can identify whole layer of some mucosa and then inject the solution into the deep layer of some mucosa. We can achieve good lift of this very loose, good dissection plane, like this. And then I explained that the usefulness of trimming for initiation of the submucosal dissection, but the trimming is also useful for compression of dissection, submucosal dissection as well. Because, so this is initial shallow incision. And then after that, we make incision line deep enough until surface of muscularis propria. So if we have a very good deep groove, we can easily complete the submucosal dissection. If there is many tissue in this last part, sometimes be difficult to complete. And last part, as distal part as well. If we achieve a very deep mucosal incision, submucosal dissection can be easily completed. So before submucosal dissection, deep mucosal incision is very important. But anyway, after such trimming, we start dissection. So I explained about the importance of gravity for the some ESD for the submucosal dissection. But the region bit difficult to perform submucosal dissection with conventional method, traction, underwater pocket creation method is useful to achieve good submucosal tension, tissue tension. So most simple and most commonly used method is clip line traction. So especially it is useful for upper GI ESD and esophagus multicenter randomized control trial proved that clip line traction significantly reduced the procedure time. And also upper GI gastric ESD, unfortunately overall significance, but not proven for reduction of procedure time for gastric ESD. Probably because lesion in a corpus or antrum, as I mentioned, if we can use gravity, the submucosal dissection can be easily performed. However, the lesion located in a bottom of gravity, like a gastric body greater curvature, in such situation, clip line traction was useful to reduce the procedure time significantly. But the issue of clip line traction is we have to withdraw the scope to apply the clip. But for example, like a lesion, proximal colon, we have to withdraw the colonoscope and then apply the clip and insert again. So in such location, internal traction method is very useful. So this is one Japanese product which has a spring and then which has two clips in the both side. So it is not necessary to withdraw the scope, and then we can insert this type of device through the working channel, and then we can achieve traction. And this is may be available only in Japan, but recently some company produced the device. So you can use such kind of devices. And the most cheap and then easy device to use for usage for the internal traction is rubber bands or braces. So you can order via Amazon. And then you can use it internal traction of ESD. And one important technical aspect is sometimes we want to achieve very good traction. So sometimes they put traction to the opposite side or distal side to the endoscopic view. But in this situation, after proceeding performance of submucosal dissection, the flap is open up more and more, and then traction becomes weak at the latter part of the procedure. So it is better to put traction to the proximal side of the lesion, so that we can really maintain the traction. And then even we proceed the submucosal dissection, we can keep the same traction to other tissue. Just a technical tip. And that is a traction device, clip line traction or internal traction device. But another is recently it became very popular, but underwater procedure, underwater ESD. Some doctors explain as a water pressure method, but conceptually almost the same. We use submucosal tissue buoyancy by the water to get the adequate tension to the submucosal tissue. So this is very useful in case of lesion located in a gravity side, because water is theoretically, naturally poor in this region. And then the water buoyancy spontaneously flap up the region, and then we can maintain the adequate tension of the tissue. And then we can continue the submucosal dissection with this method. Okay. And then at the last method is a pocket creation method. So compared to conventional flapping creation method, we can create a pocket underneath the lesion. And then we can, if we use cap, we can achieve adequate tension to the tissue with using a cap. And then this is a one multi-center randomized control trial. So this study shows that the ESD self-compression rate, ESD compression rate with single method is higher with pocket creation method compared to conventional ESD. But the unblock resection rate, R0 resection rate procedure time does not show significant difference. But a recent meta-analysis showed that the pocket creation method shows higher R0 resection or unblock resection, or shorter procedure time and low perforation rate like this. So in summary, how to choose? During ESD, achievement of adequate tension to the tissue is very important. So I think still basics is a conventional ESD. So it can be applied for universally applied to the all organ. And then understanding of basic strategy, identification of submucosal plane or identification of vessel to prevent bleeding. This is important. And maybe in a practice, still clip line traction or internal traction is a standard traction method in case of difficulty in conventional ESD. And upper GI, we withdraw and use clip line traction. And then proximal colon, usually we use internal traction. Underwater ESD is useful for esophagus or duodenal colon, which has a thin gastric wall and less vasculature. Because once it causes bleeding, it's very difficult we have to suck up all the water and then infuse the water again. So maybe gastric corpus or rectum it is bit difficult to do it. So I think very useful for esophagus, duodenum, or colon. Especially duodenum is very important. And as I mentioned, prophylactic vessel coagulation is very important for underwater ESD. And pocket creation, I usually use esophagus, very large esophageal region as a tunneling method, or colorectal region, large colorectal region, like a similarly tunneling method. Maybe especially useful for region with some large nodule which may have a central scar. In such region, I think pocket creation method is very good. Okay, that is my talk. Thank you for kind attention.
どうもありがとうございました。素晴らしかったです。Vamos a ver. Uedo Sensei, Ohata Sensei, domo arigato gozaimasu. Han sido 2 presentaciones magistrales. Ahora iniciamos la parte más enriquecedora de la noche, que es la discusión. A todos los residentes, fellows y colegas conectados, en este momento pierdan el miedo y tenemos en pantalla 2 de los endoscopistas muy brillantes a nivel mundial, ¿no? Así que por favor no sean ¿cómo se llama? Vamos a ver. For both doctors, I've noticed that you use a thin colonoscope. Should we switch to this kind of scopes, thin scopes, to better perform ESD?
Thin scope means a pediatric colonoscope. I think most of the Japanese endoscopists use a pediatric colonoscope for the procedure. How about Ohata Sensei? Especially some mucosa dissection is easier. Getting to some mucosa is easier. So we prefer pediatric colonoscope.
Yes. I completely agree with Uedo Sensei.
I think it's better for a pocket method, right?
And also maneuverability is good, and also flexibility is high. Sometimes the colonic lumen is narrow and tortuous. So I think pediatric colonoscopy is easy to handle.
Okay. Question for Dr. Ohata. Does de novo colorectal cancer grow more quickly? Is this expansive morphology common or not?
音がちょっと悪いな。
聞こえませんか？
ちょっとね、音が小さくて聞こえなかった。
でノボ、聞こえますか？
聞こえますか？はい。Does the de novo colorectal cancer grow more quickly? Is this common or not? How your experience?
I think so. I think the grow more fast, quickly than the adenoma carcinoma sequence pattern. Yes.
Okay.
So that is the reason why the Japanese doctor carefully find the small but tiny depressed type lesions.
Okay. And how about in the young patients? Is much common in these young ages? Wakamono-tachi?
I don't know the actual prevalence according to age.
Okay. One question for Dr. Uedo.
Yes.
In the underwater technique, is there a difference between using water or saline regarding the thermal injury during the cut? Which one do you prefer?
That is a good question. So basically, saline really conduct the electricity. So the electrical energy is a little bit reduced. But in our practice, we usually use normal saline. So actual outcome or output is not so much different, so still feasible. But the original underwater method is use tap water, which does not conduct the electricity. So some doctors still, and also, do you know gel? Currently, we have a gel, more viscous, liquid or
hyaluronic acid.
underwater. No, not injection. So almost like an infuse to the lumen instead of water. Little bit viscous gel, and then it does not really conduct the electricity. So some doctors say that it's better because the electricity really focused, concentrated to the tip of the device. And also it does not really diffuse the blood. So even in case of bleeding, we can still maintain the good visibility underwater or under gel. So, but the disadvantage is still be expensive. So still not so popular. So most of the doctors still use normal saline. So maybe saline or tap water doesn't matter in general.
Perfect. Thank you very much. Dr. Ohata, what
Yes.
are your main criteria for performing prophylactic closure after colorectal ESD? How do you treat the lesion after your resection? Do you close or do you leave it like this?
Indication of closure. Probably currently nobody have clear answer, I think.
But recently the closing becomes very popular. So, but we are doing that day surgery ESD. We are doing a day surgery, same day discharge. So in case of the same day discharge, for my safety, so and also for the patient safety, we close all the cases. But,
Probably still no.
In my experience, so that to prevent the delayed adverse event like bleeding and perforations, the closing acts important role. But no one knows what kind of defect should be closed.
I think it's better to choose very high risk patient for delayed adverse events. And I read one article. So if we choose a proximal colon lesion larger than 2 centimeter, it can be cost effective. So even number of clip, once bleeding develop, patient come back to hospital and then admission something. So it can be cost effective. But universal clipping, including very small lesion, it's not cost effective. So it's a little bit depend on the situation, price of the device or price of clip, something also affect.
From my experience, of course, if I injure the muscle layer, the thermal damage to the muscle layer, to prevent the delayed perforation, so we close.
Of course.
Yeah, the delayed perforation is, I think, most fearful adverse event. Bleeding is the quite rare and also severe, but
manageable.
Perforation is very fearful. So, but I think the closing quality is also very important to prevent the delayed adverse event. To close without the cavity and beneath the closure is very important. So make a cavity under the closure, beneath the closure. The defect will easily open. So close the defect and to eliminate the dead space under the closure is very important. That is the quality. The method is not important, but eliminate the dead space under the closure is important, I think.
Okay, I understand. Another question. Dr. Ohata, what's your strategy for managing dense fibrosis in recurrent lesions following the prior resection?
If we face to the tough fibrotic cases, we use two tunnel techniques. Yeah, both side of we make a tunnel both side of the fibrosis, and enlarge the tunnels and finally connect.
Okay.
When we face to the difficult cases or muscle retracting cases, like double tunnel technique or butterfly technique, someone reported. Yeah.
Okay.
I think we reported double tunnel, and Toyonaga sensei also reported as butterfly technique. Yeah.
Okay. Thank you. Dr. Uedo, for LST lesions adjacent to the anal margin, is ESD feasible despite the presence of hemorrhoid plexuses, or would surgical intervention be a better option?
That is also a good question. So, in practice, usually we use lidocaine for injection, and then, so how can I say? We usually cut surface mucosa, and then expose the varices, and then just touch with the forceps, like a coagulation forceps, and then use soft coagulation. So that usually varices or vessel usually shrink. And then after shrinkage, we bite the vessel and then completely coagulate. So if you can use such technique, I think near the or region near the hemorrhoid or even above hemorrhoid still feasible.
So in this area, in the anal area, do you start from the anal side?
Yeah, anal side.
Or from the anal side?
Anal side. Very same principle to region near the narrow channel, like a cardia or pyloric channel or extend to the duodenum. It's better to start from narrow area and then shift the region to open area. And then otherwise, if you start from open area, everything shrinks into the narrow space. At the last moment, it becomes very difficult. I think that is a basic principle. Yes.
Perfect. Another question for Dr. Uedo. What do you think about accessories like track motion? Any track devices? What's your preference? The traction devices?
You mean internal traction device or clip-on line or?
Which one do you use to?
So as I explained in the presentation, so region location easy to withdraw the scope and reinsert. We usually prefer to use clip traction. So esophagus and the stomach or even rectum clip traction, useful. Otherwise, region located in a proximal colon or sometimes duodenum, we use internal traction. And then any method is okay. Recently, many different devices, but just a simple clip-on line traction or rubber band internal traction works almost similar, I think. So it's better to choose one and then practice to improve. familiar, too familiar with one technique or one device.
Okay.
Yes.
This question probably for both. Many Japanese masters, endoscopy masters, do not use dye when creating the submucosal cushion. Is there a specific reason for this, or it's better to see all the perforating vessels? Do you prefer that, or do you prefer to do with some indigo carmine or some dye?
So probably standard. I think standard procedure still most of the doctor use dye added solution. But in my practice, we usually use transparent injection solution without dye because it facilitate recognizing the submucosal fiber or tiny vessel. So in my preference, I don't add dye, but some doctors still use. And then previously, they use very high concentration, very dark color. But recently, most of the doctors use very light color in order to recognize the submucosal vessel. That is current trend, I think, in my understanding. Yes. How about Ohata sensei?
I completely agree with Uedo sensei, but I think the color is I think it's just a matter of getting used to it. Yeah, I like so I'm using a bit dark indigo carmine, but I'm getting used to use that kind of solution, but doesn't matter. Yeah.
In Peru, I started with no color because we don't have the dye, but afterwards we have also hyaluronic acid and indigo, methylene blue.
Methylene blue.
But yeah, I can understand the color could be a difficult procedure because all dark, or you can easily can't see the submucosal layer, no? So probably depending of the performer, the endoscopist. Another question is, what do you typically use for submucosal injection to achieve lesion lifting? What's your formula?
In Japan, we have a hyaluronic acid, so standard solution is hyaluronic acid. Yes. In my practice.
Dr. Ohata, you also use standard in Japan?
Yes.
I think so.
Yeah, we in Peru we also have the hyaluronic acid also. This gel do you use for underwater, is this Visco Clear? Is it?
So Visco Clear is I explained that gel specifically for underwater procedure, under gel procedure. And then previously we used in some patients, but still not the standard device, such standard solution for our practice. Maybe cost or just saline can work very similarly. So, but for sure quality, I think Visco Clear is better than normal liquid because we can really identify the bleeding point in case of bleeding during the procedure.
Okay. How do you distinguish deep SM2 invasion from inflammatory or dermoplastic changes that may mimic advanced malignancy? In your experience, is this distinction always possible? What can you offer us?
It means a distinction between submucosal invasion versus inflammation.
Yes.
According to endoscopy view.
Okay.
Does it mean the NBI finding or conventional finding? Or
so when we are doing the diagnosis
during the what?
During the
treatment.
Yes.
Before.
Before the
Yeah.
during the diagnostic procedure,
Mhm,
procedure,
mhm,
some inflammatory changes could mimic advanced or more deep invasion. So, what do you suggest in these
I see.
cases?
Maybe I cannot really imagine. So it's
So there
kind
are
of
some cases.
ulcerated region or
For example, we have a patient with inflammatory colon disease, no?
polypoid. Inflammatory
And then
okay.
so or ulcerative colon, and
Mhm,
afterwards during these inflammatory changes we can see
mhm,
some lesion.
mhm.
And how can you tell us if it's deep invasion or just inflammatory? So you should try doing the dissection, or a little bit difficult?
Difficult maybe, but basically if you are familiar with NBI finding or NBI diagnosis, I think still it can be distinguishable because usually inflammation is really exist in the surrounding normal mucosa, but usually invasive cancer exists in the surrounding of like a adenoma or intramucosal lesion, intramucosal adenocarcinoma. So if we really evaluate overall morphology or overall structure, I think still, you know, really central part can be very distracted surface structure or irregular vessel based on invasion or inflammation, but the surrounding mucosa or characteristics is completely different between inflammatory change and neoplasia. So,
No. Okay.
mm, mm.
Dr. Ohata, could you briefly describe your training program structure, the typical learning curve, and the key requirements for achieving expertise in magnification and enhanced endoscopic diagnosis? So, how is your training program structured in your center? How is the learning curve and I don't know, the key achievements to say, this guy is an expert?
But my training program and basically the 40 cases of the colonic cases, and then in my center independently perform the ESD. But some Western reports mentioned that maybe 250 cases is necessary. Some report, some
Okay.
paper reported. So to be an expert, so many cases is necessary. But basic regions, conventional style and the basic region like not so special cases. 40 cases is one of the milk model to perform independently in my
Mhm.
center. 40
Okay.
colonic cases. Yeah.
Okay. Another question here is, in elderly patients or poor surgical candidates with clinical T1 rectal lesions, what is your experience performing ESD or endoscopic intermuscular dissection as a diagnostic therapeutic tool to assess pathological risk factors for lymph node metastasis? So, what do you choose in elderly patients?
So intramuscular dissection. So I think deeper is better if we suspect T1 lesion. So that is our strategy because it's better to have enough, vertical, margin distance,
Yeah.
section margin.
Okay.
And of course, before do that, we check by EUS how it reached, completely
Lymph
reached
nodes.
the
Yeah.
muscle.
Okay.
Yeah.
Okay, okay, okay.
Mm.
Perfect. Another for Dr. Uedo says, when dealing with fibrotic or poorly lifting colorectal lesions, do
Mhm.
you follow a predefined algorithm, or is your strategy determined dynamically during the initial minutes of the procedure? How do you uh, like plan your dissection?
So I think actual fibrosis is very difficult to predict before dissection. So in our practice, yeah, we sometimes little bit suspicious for submucosal fibrosis, but I mean submucosal invasion, but patient is very poor candidate for surgery. We usually start the dissection and then try as much as possible. I think some such kind of situation can be happen. Yeah. And then at that time, pocket creation is very useful. So we usually dissect both lateral side of the fibrosis. And then after that, we try to dissect remaining fibrotic part. Yes.
Okay. Okay.
Mm.
Dr. Ohata, which endoscopic findings of SM2 or deep submucosal invasion would lead you to discontinue an ESD procedure? Which endoscopic findings of deep invasion would you decide
during the
to
dissection?
stop? Yeah, during the section. So you're doing the dissection, and which features, endoscopic features, do you see and say, no, this is more deep. I will discontinue and stop.
Muscle retraction, maybe. Yes.
Yes.
Okay, okay, okay. Okay.
Almost the fibrosis really almost involving the muscle. That is
Okay.
very difficult.
If there is a muscle retraction sign, we stop the procedure. But if if we judge if it's possible to remove and broccoli, we will continue the dissection. Maybe. Depend on the degree of the muscle retraction.
Okay.
So severe retraction, and it's difficult to identify the deeper dissection layer. It's difficult. So we stop the procedure.
Okay. Okay.
It's difficult.
Some update of the former question was a track motion is a device from Fujifilm that is becoming popular in Brazil, and it looks like a robotic ESD device. Do you know about this?
Track motion.
Track motion, yeah.
Not traction system.
No traction system. Track motion is the name of the device. I think I've never.
From Fuji.
From Fujifilm, yeah.
Oh, sorry, I don't know. Track motion 知ってます？
Track motion, what is that for? Traction or like a
no, it's a name.
AI or
it's a
device.
Fujifilm track motion retraction device for ESD.
Toyonaga sensei develop. No, that is a different company. I don't know.
Probably it's a.
知らない。
Track motion.
No problem. For general gastroenterologists, referring lesion for ESD, what key endoscopic features must be carefully documented in the initial report? So, what do you expect from outside patients? What is the description do you need for the initial report?
So I think actual size. I think most
Okay,
of the many information can be involved in a determination of the indication, like size and then predictive depth of invasion
Okay.
and location.
J.
Yeah, that is for maybe esophagus, colon, stomach, or. And then besides gastric ESD, usually indication include histological type and also presence or absence of ulceration. So if we can have such kind of information, we can determine the information. And then actual size is very important. I have been to different countries like Sweden. Many patients referred as a large region ESD, please. And large can be 2 centimeter or can be whole circumference. So very difficult to plan the devices and rooms and the stuff. So actual size is very important, I think.
Very important. Okay. Ahí, muchas veces pueden marcar la pinza de biopsia en centímetros para poder medir el tamaño o más o menos aproximar el tamaño de la lesión, ¿no? Con un marcador lo pueden marcar la pinza de biopsia, la longitud para poder medirlo, ¿no? The final question, what are your thoughts on using AI-assisted diagnosis to determine the invasion depth or biological behavior of early gastrointestinal lesions? How about AI diagnosis?
I think still not available, but maybe in the future, if you train the computer with that algorithm, maybe it will be available in the future. But the most important thing is sometimes we really misunderstand that the AI can really produce 100% diagnosis. But basically, even AI, we just evaluate morphology and then really assess or predict the depth of invasion. So AI can really reach to very close accuracy to expert. So for beginner, it's okay because it improves diagnostic accuracy to expert level, but it does not really, expert level to 100%. So, so maybe general practice,
AI.
yeah.
You don't
Still in a practice, we don't use much. Not really integrated in a clinical practice so far, but maybe in the future.
Okay. Well, there has been all the questions.
So
hemos llegado al final.
Just saw the Fujifilm track motion. Fujifilm track motion. I checked. It's a very good traction system, but it required 2-channel endoscope. The endoscope itself is very thick, and the 2-channel endoscope is difficult to get in some mucosal space. So, and also the traction moves in parallel with the knife. At the same time. So move together. So if the traction is separately play traction, it's good. But move with a knife, I think it's not so good.
Okay.
So the traction and the knife should be moved separated.
Okay. Thank you for the update. Thank you.
Yeah.
Well, hemos llegado al final de esta sesión histórica. Hoy hemos sido testigos de la filosofía japonesa aplicada a la medicina, ¿no? Búsqueda siempre de la perfección del Kaizen en beneficio del paciente, ¿no? No sé si la doctora Cabrera quisiera algunas palabras antes de cerrar todo.
Sí. Antes que nada, it's been a really great session. We really appreciate your participation. Thank you, Dr. Uedo. Thank you, Dr. Ohata. Muchas gracias, Dr. Kishimoto. Y a todos ustedes, colegas, les agradecemos mucho su presencia y los esperamos en nuestra próxima sesión presencial el 17 de marzo. Muchas gracias.
Ohata sensei, Uedo sensei, どうもありがとうございました。
ありがとうございました。はい。お疲れ様でした。
ありがとうございます。また今度、
お疲れ様
よろしくお
です。
願いします。
お願いします。
はい。では、ありがとう。
はい。
Muchas gracias.